Prevalence, Leveraging Qualitative Data for Effective Prevention, Part 2. As you all are joining, if you can put your name, your role, and where you're from, that would be great so we can get to know you a little better. We do anticipate a pretty large turnout today, so feel free to populate the chat, and we will make this as interactive as we can with a very large group. So I see Chris has posted already. Great, thank you. Awesome. And Katie will be primarily presenting today, and I'll just get us started to talk a little bit about our quantitative data, and she will then take over to dig into this qualitative. Thank you all for posting in the chat. All right. Well, if you're just joining today, we are going to be talking about part 2, meth use and focus, leveraging qualitative data for effective prevention. Katie Shakoyan is here, and we will introduce her in a minute, but we are glad to see all of you here. We just want to acknowledge today that this information has been prepared by the South Southwest Prevention Technology Transfer Center at the University of Oklahoma's Southwest Prevention Center, and you can see our information there. We do work under a cooperative agreement with SAMHSA, the Center for Substance Abuse Prevention. If you have questions about anything in today's presentation, please email us at pttc6@ou.edu. So we are on our meth use and focus journey, and we are now at part 2, where we're going to talk about the qualitative data. In part 1, about a month ago, we talked about leveraging the quantitative data for effective prevention, and we'll give you a recap of that also as part of today in case this is your first time joining us. But today we are really going to focus in on the why. So we talked about some gaps in part 1 with the quantitative data that we looked at with both the National Survey on Drug Use and Health as well as CDC Wonder, and then looked at how we could maybe explore that further. So today we will unveil some of that exploration that goes into the why and the context. And then we would love for you all to join us for part 3, where we actually release our data brief. That will be a shorter webinar as kind of the finale, putting this all together into a nice document and product that you all can share with your communities and organizations. So today we have Katie Shakoyan with us. Katie is going to present on the qualitative portion, and she currently serves as the epidemiologist for the South Southwest Prevention Technology Transfer Center. She provides training and technical assistance to support regional clients to employ epidemiological data in their assessment and implementation of prevention efforts. She has over 15 years of experience on the ground and through research and evaluation working to address social public health issues. She also brings expertise in qualitative data analysis and research to the work of using data to inform prevention assessment and planning. So I will turn it over to Katie. I am Nicole Shaneborn. I'm the evaluator for the PTTC. And then we also have Sheila with us, who is our evaluation and design coordinator. And we work as a data team here for the PTTC. Katie, I will turn it over to you.
Thank you so much, Nicole. And it's great to see all of you. And I try to keep my Zoom windows open while I'm presenting. So if you want to have your camera on, I will glance over at you and see whether or not you're totally lost or not, but no pressure. So today, in the hour and a half we have together, our goal is that you are able to use some existing qualitative data to fill gaps that are left by the quantitative meth use and mortality data in the South Southwest region specifically. Although I do know a number of you are joining from other parts of the country, and so this will be applicable to your work as well. We're also hoping that you all will be able to identify a variety of qualitative primary data collection methods, and then develop a qualitative data collection plan to better understand an existing or a gap in the existing quantitative knowledge regarding meth use. To do that, we're starting with introductions, which we've already jumped in on. We're going to do a little recap. I am going to pass it back to Nicole in a minute on the trends and impacts of meth use and gaps in the quantitative data. Then we're going to look at the qualitative data through a socio-ecological model, looking at what some of those drivers of meth use are. We'll then talk about qualitative data collection plans, do a little sneak peek on that next time Lunch and Learn data brief release. And then, of course, because we're data folks and we do it anyway, but especially because we're data folks, we definitely want to get your feedback in our evaluation. Let's see. So before I pass this over to Nicole, I just want to ask you all, many of you did attend part 1, where we really talked about the quantitative data trends around both meth use and mortality. And I'd love to hear from you, and feel free to come off mute or to put it in the chat. What do you remember from that webinar, or what have you found in your own communities about the trends around meth use? And I'll pause for a second, but please feel free to come off mute or put it in the chat. And that question is just either what do you remember about quantitative meth trends, or what have you found in your own communities? To be honest, I don't know anything about trends in my community in this area. Thank you for your honesty there. And I think that you are not alone in that. Susie says it's increasing again in our area. Yep, that makes sense. Good. Some people agreeing with not knowing what's going on. Anyone else want to add a thought before we jump in? If you are writing out a long, well thought out piece, you can continue to type it in that chat as we go forward. Denise says in our area, we're seeing an increase of both use and death. Yeah. And I'll let Nicole talk about that in a minute, but I think that's a lot of what we're seeing. So the background is just sort of a basic background on methamphetamine. It's a highly addictive stimulant. I think many of you know this. It can be used by smoking, snorting, injection, or through ingestion. And meth has the effect of a really short-term, very intense euphoria that causes people to seek more and more of it pretty quickly after using. That can lead to these long-term health and social harms. And so that's just sort of grounding ourselves in the substance that we're talking about. And I'm just checking, it looks like Mackenzie is saying our area is trending down from the past decade or so, but the presence of fentanyl is skewing our data. And yes, we're definitely seeing that co-use between opioids, including fentanyl and meth. And we're seeing Dr. Phyllis Kibler saying both use and arrest rates are included there. Thank you. All right, let me pass it back to Nicole to just recap some of what we do know quantitatively about meth right now.
Sure, thanks, Katie. Well, just to recap some of our quantitative trends, if you remember, those of you that were with us, we looked at both the National Survey on Drug Use and Health, as well as CDC Wonder, to look at some of the quantitative data. So let's take a look at NSDA first, and we're going to pull up the map here from NSDA. So this is the national look at use in the past year among individuals aged 12 or older, and this is by state, and the years for this are 2022 to 2023. So as you can see in Region 6, and our states are New Mexico, Texas, Oklahoma, Louisiana, and Arkansas, you can see that we have several states that are shaded darker, which means we have a higher prevalence of use in those areas. And so these NSDA data show higher state use prevalence in New Mexico, Oklahoma, and Louisiana when you compare the rates nationally. And Region 6 has several states with some of the highest prevalence of meth use. So on the next slide, we're going to look at the breakdown of our states a little bit in more depth. So with the total US, the meth use prevalence is 1.03%. So when you look at our region states, this kind of gives you an in-depth look here. New Mexico is at 1.94%. Louisiana is at 1.64%. Oklahoma is at 1.61%. And Arkansas is at 1.55%. So the only state in our region that is below the national average is Texas. So, and this is for use only. And so on the next slide, we'll look at, just recap our mortality data. So this is the methamphetamine mortality rate in the South Southwest region and includes the overall US from 1999 to 2023. So you can see the national rate is that dotted line there for the total US. And you can see that that kind of steadily increased from 1999. And then we see that sharp increase around the 2018 to 2021 era. And then if you look at our states, you can see that New Mexico is rising up above that substantially. Oklahoma, Louisiana, and then we see some interesting patterns. When we think of Texas, we just saw the use data, but this is the mortality rate data. And you can see that in the past year or so, from 2022 to 2023, there's a little bit of an increase there, but we also saw increases along the way. So that's why it's important to look at both use and mortality, because we can start seeing some different patterns. We also see that Arkansas started decreasing. We also saw some decreases in Louisiana in the last year or so. And New Mexico had kind of a plateau there after that sharp increase. So digging deeper is always good. And the mortality rate can really help you look at another aspect of meth use. And this may be related to some co-use of opioids, et cetera. So I will now turn it back over to Katie.
Thank you. So that sort of very, very high level picture of what some of the trends are we're seeing quantitatively around meth use. I'm curious to hear from some of you with that little snapshot of the numbers. What are some of the questions that you have or that are remaining for you that you want to understand about both meth use and mortality right now? And I will also use this as a plug to let you know that you can watch the recording of our first session and see a much deeper dive into the quantitative trends than Nicole just went through, if that is interesting to you. But what are some of the questions that come up for you when you see the sort of sharp rise of both use and especially mortality rates for meth in the South Southwest region? Hard because it's hard to give folks enough time to think about an in-depth question like that in this space. So go ahead and take a second. And again, you're welcome to come off mute or put it in the chat. Where is meth production the highest? Yeah, great question. And one of the trends that Nicole was able to look at in that part one of the webinar was looking at how methamphetamine is making its way into this country and some of the sort of highway corridors that are leading to that. We do know that meth production has moved for the most part from domestic production to substances that are being imported from Mexico primarily, but from outside of the country. Yeah, some other questions. So connections to borders and cost being a big one. Yep. Is there any link between COVID and meth use or deaths? Are the deaths contributed to meth found to be mixed with other drugs like fentanyl, or are these individuals passing away to things like heart attacks? That's a great question. And some of that we'll go into today, Mariah. But just to clarify, because this has come up in a couple of other settings where we've had these conversations. So the numbers that are attributed to meth deaths are a cause of death that also has meth attached to it. So it's not necessarily only people who are using only methamphetamine. There's lots of co-use in there with fentanyl and other opioids. And it could be a heart attack that also is associated with meth. So yes, it includes all of that. Thanks, Nicole, for dropping that in there. All right, so these are great questions and there's more coming. I wanted to share with you, so at the end of our part 1 webinar, we asked folks to fill out a Padlet that asks the same question. What are the questions that remain at this point? And here's just an example of some of what folks came up with. So, is there a link between meth use, fentanyl use, and homelessness? Why is there a resurgence in use and mortality now? What's happening at this point in time? What's happening in the small communities with suppressed data, including rural and frontier counties? So that refers to any data that's collected if there's low enough numbers that we won't actually get the reports on the national data level, of data on the national level. So there are questions about what's happening in those areas as well. What are the most recent trends? Nicole mentioned that this data was 2022, 2023 combined data for the most part. What's been happening in the last year or so? What are the impacts of COVID on meth use prevalence? And that was what came up from you all in the chat as well. And what are the reasons for usage? What are those underlying needs that are not being met? Some of these we might be able to collect some more quantitative data to get a little bit more insight into. But what we're really looking at today is how do we understand the kind of context questions that aren't going to necessarily show up in that large-scale epidemiological quantitative data. And I'm seeing that we did have another sort of question coming in the chat, the link between meth use and the previous shortage of ADHD meds, which I think is really, I'll be interested, Vanessa, to hear your thoughts as we go through some of these findings and see if anything clicks for you on that. So today we're going to take a mixed methods approach. So mixed methods really is any time that you're using data from 2 or more different types of sources to come together and really triangulate or try to understand from a lot of different perspectives what is going on in that sort of root issue that you're trying to understand. So we're taking some quantitative data that we explored in our last session. We're adding some qualitative data in today to really get a fuller picture of what's going on. So here's some qualitative data on methamphetamine use. And to get there, we need to start with just sort of a really basic, brief overview of what qualitative data is. So could you please throw in the chat, or again, feel free to come off mute. I like to hear your voices. What do you know about qualitative data and how is it different from quantitative data? Great. I see some thumbs ups. I'm curious what you know. Narrative, detail, really rich data. Thank you. Yep. So definitely more of a focus on the narrative, the story, what's going on, less about numbers. Qualitative shares a story on the data. Yes, stories and description. Great. More about personal experiences rather than numbers itself. A narrative with words. Quantitative is more numbers. This is great. Qualitative can be the human side of data. I like that a lot too. Yeah. So we're looking at characteristics versus quantity. Love that. Qualitative data, words, images, it's non-numerical. That's kind of the key distinction between quantitative and qualitative, right? It's really based on, it's interpretation based, and it can be descriptive, also based on experiences and perceptions. It can be collected through interviews with impacted individuals, through focus groups or listening sessions, which are more these sort of group settings where we get information, open-ended survey questions, key informant interviews, which would be interviews not necessarily with folks who are impacted, so maybe not folks who are using meth, but with folks who work with them, right? So it could be somebody who does prevention work in the community. It could be someone who does recovery work in the community who has a lot of experience with different people who who have used methamphetamine. Can also be done through observation. So it's places where you're not necessarily asking questions, but you are observing what's going on and collecting data in that way. I'm going to go back. I just know there were a few more that came into the chat. So quantitative is number related. Qualitative can be language. It enables one to understand on an emic level. Can someone, is it Dr. Simon or Simeon Goodwin? Would you just elaborate on that a tiny bit?
Yes, emic versus etic, more of a micro understanding, especially if you're trying to understand in cases like the cultural impact. The emic is much more involved in terms of basically covering some of the items you just listed.
Yeah, thank you. That I didn't have that language previously, and that's really helpful to me. Thank you for that. So
Sure.
really understanding more on that kind of person to person level, what are people's experiences? Yeah. So we collect qualitative data to understand how and why. So I think about quantitative is what and how much. Qualitative is how is it happening? Why is it happening, right? We can really attend to that context. Qualitative data can allow us to give voice to underrepresented participants and to better understand groups that have smaller sample sizes. So we're really trying to, those numbers that might be suppressed in a large quantitative report, we can understand them better through these qualitative methods. We can also uncover unexpected patterns or relationships, and qualitative data has the potential to support the interpretation of quantitative findings. And you can kind of do that in either way. So you can take, like we're doing right now, our big quantitative data, understanding what are the trends at the national level and the state level, and from there determine questions that we want to ask to specific groups within that larger set. Or you can start by talking to people, maybe doing some focus groups, some interviews to determine what the questions are that we would want to ask at a quantitative study. So they can I consider them to really go hand in hand to get a more full picture of what's going on here. Qualitative data can give us a lot more information about the context of meth use in this case to better understand why and how it is happening. And then one way to really organize the qualitative data that we are seeing is through the socio-ecological model, which I know is a model most of you are familiar with, but it's a way of understanding not just how people are making choices or how people's health is impacted, not just by their individual experiences, but also by their interpersonal communities, by their larger community, by society, all these multiple levels that are impacting an individual's and an individual's health. So this particular image is adapted from one of the qualitative studies that I'm going to tell you about in a minute. They organize their findings by the different sociological levels, socio-ecological levels. What we did, and again, I'm going to tell you a little bit more in a second, is we found a number of studies that really looked at qualitative understandings of what's going on with meth use recently in the South Southwest region or areas that are similar. And we added some of the other findings into this graphic for you as well. But here's one way that we can think about these pieces. And we're going to come back to this, so don't feel like you have to memorize it all right now. We're going to be kind of exploring it and coming back in. So using the search function on our university's library's website, I was able to pull together 4 qualitative studies that were done on meth use in the last 5 years. We use the search terms qualitative and methamphetamine, so there's not a whole ton of overwhelming amount of this data, right? There's a couple that really are relevant in one way or another to the South Southwest region that were done really recently. These are the 4 most relevant to understanding the context of why people in our region may be using meth. So the first study from Hansen et al. Is a 2021 qualitative study with interviews of 20 Appalachian Kentuckians who reported lifetime opioid use and past 30-day methamphetamine use. So we're seeing that co-use between opioids and meth in this space. The next, which is Harding et al., is a 2022 study of 21 qualitative interviews with people over 18 who reported using meth in the previous 3 months in either Nevada or New Mexico. So New Mexico is one of those South Southwest states. The Ondoxin study is a 2023 study. It was a rapid ethnography, which is more of that observational study for folks who are less familiar with the qualitative methods, but it did include some semi-structured interviews of 30 people who injected heroin and or fentanyl and also used methamphetamine, and that was in West Virginia. And then the Silverstein study from 2021 was of interviews with people who use both heroin, fentanyl, and meth. And those were folks in the metro area of the Southwest Ohio. So these are not huge sample sizes, right? That's one of those distinctions that we often see between quantitative and qualitative data. But each one of these has a pretty sizable set of folks who they were able to talk to, get some patterns and trends, and understand some of what was going on with meth use. I'm going to be sharing some quotes from these studies in the next few slides. And to do that without you having to listen to me over and over again, and I'd love to have some of you all read these quotes. So if you would be willing to read a quote, if you would just hover over the reactions button on your Zoom and raise your hand and just keep your hand up until I call on you. That way I don't have to keep pausing and say, oh, will someone read this quote? And I do have some plants if I need to ask other folks to read them as well. The last thing I'll say before we go is just, you'll see there's some typos in these, or it might not be the way you would word a sentence. These are direct quotes from folks who were interviewed for the studies. So anything along those lines comes from the participants themselves. All right, I don't see anybody's hand raised, which means that the folks who work at the PTTC are going to be doing a lot of reading. But if you are willing to read, I will call on you. And yeah, Esther, would you mind reading our first quote here? Oh, I cannot hear you. I think you're muted.
Yeah, I just realized that.
Perfect.
All right. It was, the best, to me, the best thing ever. All this energy. I didn't have to sleep because I have nightmares. I got PTSD from my childhood, and when I sleep, I have nightmares. So meth kept me awake, and I didn't have them. Nightmares, and I was better. I thought I was better. I was numbing my pain. I still know that I'm numbing my pain, but I didn't think a lot about my childhood.
Thank you, Esther. So first, the literature really describes these two main individual factors that contribute to why individuals are using meth. And the first is this attractive high. Participants described using meth to treat mental health concerns that include things like attention difficulties and mood disorders, but also as a coping mechanism for emotional trauma. Trauma was often coupled with anxieties about housing security and economic strain, maybe a lack in confidence in their ability to reach gainful employment, and a sense of boredom or perceived lack of healthy recreation options. The participants who described meth as a treatment for mental health concerns often reported poor access to psychiatric care or mentioned that the medications offered by healthcare providers did not work as effectively as methamphetamine. For most participants in the second study, opioid initiation preceded the uptake of methamphetamine. So several of them sought out meth for its pleasurable effects, both alone and in combination with heroin. One participant in his 30s who had been using heroin for 13 years and meth for 2 years tried to explain what he would call the quote unquote unexplainable embodied experience of the combination of meth and heroin. Can I ask, is it Max Newman to read the second quote on this slide?
It is. Yes. Can you hear me?
Yes.
Okay, perfect. You're on top of the world, you know what I mean? You feel good, you've got that warm, fuzzy feeling from the heroin, and then you've got the euphoria feeling you get of the ice, just a mixture or combination of both. It's kind of unexplainable.
Thank you. So that's the sort of attractive high. We're both seeing it as a solution for mental health concerns, and then also just this very euphoric experience that's driving people on the individual level. Then we start to see the second big factor, which is as a tool to suppress withdrawal off of other drugs. George, would you mind reading this first quote for me?
Sure. Good morning, everybody. Can you hear me okay?
We can.
Okay, it says meth will stop withdrawal. Did you know that? For anything, it stops for any kind of drugs. Xanax, Neurotin, pain pills, Suboxone. So a lot of people have used meth to get off Suboxone.
Thank you. So participants also described how meth use helped to suppress their withdrawal symptoms and their cravings for opioids. Several prescribed buprenorphine for opioid use disorder reported being removed from treatment after testing positive for meth, which led to opioid withdrawal and increased use of meth to treat that withdrawal. Participants also described going a day or even multiple days without using heroin or other opioids because the continuous meth use distracted them from even thinking about opioids or withdrawal. These participants noted that meth altered their perceptions of time, keeping them focused on particular tasks to the exclusion of all other distractions. This next quote is from a 35-year-old participant who had a long history of opioid use and was intimately familiar with the pain of opioid withdrawal. And she explained, or they explained, that although methamphetamine alleviated some of the sickness, it mostly was helpful because it distracted from suffering. Angela, thank you for raising your hand. Would you read this one for us?
You do it, methamphetamine, right away, and you just get lost in what you're doing, and you forget that you're sick. It does actually take away some of the sickness. Then you do forget that you haven't done heroin in 4 days.
Thank you. And I'll ask if other folks are willing to read or read again, please do raise your hand. That's working really well. Finally, when asked whether they or anyone they knew had experienced what they believed to be a methamphetamine overdose, reports of fatal acute meth overdose were rare, and some interview respondents asserted that meth overdose is not possible. This is an example of what one respondent said, and I'm going to ask Nicole on our team if you would read this one.
Sure. You can't OD on meth. I don't care what they say. You blankety blank, nod the blankety blank out. Maybe you have a weak heart of something or it gives out. Okay. Then yeah, you die, whatever.
Thanks, Nicole. So this goes to the question that came up in the chat before, right? We see folks a misunderstanding that meth can cause an overdose, but also seeing that, we're seeing associated, we're seeing causes of death that are not solely methamphetamine, but people who are using are sometimes attributing that as being only caused to their heart condition, and that the meth itself isn't actually that dangerous. All right, so we're going to now shift up a level in that socio-ecological model and think about social access and ease of access among family and friends. And can I have Laura, will you read this quote, please?
I was 15 when I first tried meth. I seen one of my friends that I had not seen in a while, and she tells me that she had ice cream. I didn't know what it was, and my person that I got weed off of was out. So I gave her 20 bucks, and she told me to Google what ice cream was. I was looking for weed, but as soon as I first took my first hit of meth, I was like, oh my God, because I fell in love.
Thank you, Laura.
You're welcome.
So participants' initiation of meth use was often facilitated by members of their drug networks. Many participants in this study indicated that they had first tried meth passively or even accidentally with people who are already in their drug networks. Several younger participants also described trying meth without even knowing what it was. And this particular quote came from a 19-year-old who that was his situation. The next quote is related to the sort of social aspect of meth use. So this quote I'm going to show right now is from a participant in her late 30s who had been using heroin for 5 years and meth for 2 years. And she described disliking meth, but still using it socially with her boyfriend to synchronize their time together. I will re-up my request for hands raised. And also, Wanda, would you mind reading this one, the second quote on here?
I sure will. I don't really like meth. And she laughs. My boyfriend loves it, and I do it mainly to stay up with him.
Thank you. All right, now we're going to zoom out even a little further. We're going up from the interpersonal into the community level, where we're seeing availability and affordability of meth as really influencing the rates where it's used. Participants in the Hansen study uniformly described how meth is now the easiest illicit substance to get and how that really allows for the rapid increase in new use in the region that was included in that study. So this quote is from a 25-year-old man who talked about how meth accessibility defined his community. And Angela, thank you for raising your hand again. Please read this quote.
Meth's already took over. Meth is every corner, every street, every straight stretch you see. It's everywhere you look, meth. You know, it ain't hard to find out where it's at either. You just gotta sit and watch people doing it.
Thank you. And then talking really specifically about the form of crystal meth that's known as ice, a 50-year-old woman was really shocked at the ubiquity of ice on the streets when she was released after a brief period of incarceration. And I'll ask Nicole, will you read this one for me?
Sure. Meth is just, I mean, pow, it's huge. Like, I went to jail and was in the program because I was locked up for 4 months. And I came out and I didn't know a meth dealer when I came in. And I came out and it's everywhere. It's everywhere in that short of time.
Thank you. So we're really seeing how accessible meth is for folks and how that's really influencing the number of people who are starting to use it. We put that into combination with understanding how powerful that high is, how it leads people to seek more very quickly. That's definitely a contributor to the rates that we're seeing. On the other side, and what goes hand in hand with that, is affordability. So this quote is from a 35-year-old who had used opioids for 15 years at the time of his interview. And he was talking about noticing a really steep increase in the availability and use of meth among the local people who also use illicit opioids. I'll ask again if anyone wants to read a second one, put your hand up, but otherwise we can listen to Wanda and Nicole. Wanda, will you read this quote, please?
Yes. Methamphetamine, was really prevalent. It just all of a sudden showed up out of nowhere in large quantities and basically didn't have to pay for it. Everybody had it. People were giving it away. It was just all over the place.
Thanks, Wanda.
Mm-hmm.
And among those who were not using meth for its intrinsic or its opioid assisting effects, there was this other common theme that came up in the Ondoxin study group that they termed reluctant or indifferent use. So during that study, meth was so pervasive and relatively inexpensive that several participants commented on how it was freely traded. Participants commented on using meth if it was freely given, even if they didn't like it itself. And Max, will you read this second quote, please?
Yes, ma'am. I don't like it. I do it often. I've never paid for it. I've never paid for it because ice, especially around here, is practically free. A week's supply of ice costs around about $40.
Thank you. So again, we're just seeing that it's really accessible and it's really available. Okay, so we're going to our last level, the societal level, where we're looking at these large social conditions, things like the economy and policies around drug availability, and how they impact the patterns around prevalence of meth use and subsequent mortality. And I will ask Esther if you would read our last quote for us. You are still muted.
I like to read silently. Okay. I think mainly people are just trying to figure out a way to forget about their problems. Once they should cool down, I'm thinking. Once
It's
they
cool.
should cool down, everybody around here, it went from being a happy-go-lucky town to a ghost town. Pretty much as soon as the cool shut down, the miners went from making good money to making about minimum wage. I don't know how many of them I know lost their vehicles, filed for bankruptcy. I'd say about 50 to 60% of the ones that I knew at work in the mines have done meth or are still on meth because I guess they just didn't see no other way out.
Thank you. So we're seeing these large economic trends, right? In this case, the shift from a coal industry and a town that had been really based on the economy of coal to losing that and what impact that had on their community. That I think one of those questions that came from the first session was about what are those underlying problems that aren't being met that are leading to some of this use. And I think some of these societal level factors really get at that. The other thing that was in the literature around the societal level really described how policies that were designed to combat the opioid epidemic, things like really working to decrease prescribing of opioids by healthcare providers, impacted the availability of non-medical prescription opioids. So older participants in particular, frequently in these studies described meth initiation only after their sources of that non-medical prescription opioid dried up. This is one example of how policies and successes within the prevention field can have some unintended consequences sometimes. So while one approach can do a lot of good, and we see a lot of good coming from this goal of having fewer opioids available for misuse, we know that different substances have the same shared risk and protective factors. So we can manage one issue, come up with some really excellent, effective ways of decreasing the oversupply of opioids, right? Just for another one to pop up. And it's a reminder that as preventionists, we really do need to continue looking at those root causes of substance use that we're preventing so that we're able to really address all of these pieces. So we're going to sort of turn to a little bit of discussion. I do want to acknowledge there's a question in the chat about Oregon's decriminalization of meth. I'm going to sort of pause that to the end of our conversation. Spoiler is that I don't have a lot to say on it, but I think it's a critically important element of this. And so we will come back to it, but I'm just not able to address it at this point. What I would love to hear from you all, and again, out loud in the chat, whatever's most comfortable for you, is I'm wondering how this qualitative data on meth use really connects to or doesn't with what you're seeing in your community. And I'm wondering about, for these different socioecological levels, what are some of the driving factors that you're seeing in your own work? Easy access and low cost, that's something that you're seeing, Susie. And I do think, I just said we weren't going to talk about Oregon's policy, but that's a great example of a societal level policy, right, that will have some impact on people's individual use of meth. I think those that were actively using heroin or fentanyl became fearful of overdosing, and that false belief that meth is safer because you can't overdose might drive some of the decisions to use meth. Dealers then start to notice this trend and start to pass out meth at low cost to keep people coming back for more. I think that is a narrative that makes a lot of sense with the data that we're seeing, Mariah. Thanks for sharing that. It's in lower income and impoverished neighborhoods. I can see when we're looking at the availability and affordability, that makes a lot of sense, right? And I think that kind of leads us to think about some of these non-medical drivers of health and how do we see these patterns emerging? lack of resources to make ends meet. Definitely seeing it, especially more in the rural communities I work in, because it's so low cost. So those communities are more at risk of substance use disorder. They don't have the resources in these communities to access the help they deserve and they need. It appears that so many affected individuals are trying to manage childhood trauma. Yeah. And all of those underlying pieces, underlying issues that are leading to the seeking this substance use in different ways. And definitely we're seeing that in meth. Hearing from students that if their ADD, ADHD scripts are cut off, they often turn to meth. Yeah, and Laura, I think it was you who mentioned that earlier on too. I haven't heard that particular thing myself, but it feels very in line with what we're seeing. And for people saying, you know, meth is almost this miracle substance. And obviously, that's not what I believe. That's just something that we're hearing, right? That seems to be able to really treat lots of different things when other substances and drugs are unavailable. That's driving people to this. Hearing people talk about how closely these substances are to prescription medications, they don't feel that they're different or that harmful because of the similarities. Hearing teens say that Adderall and meth are the same. Mm-hmm. And I think, you know, this isn't directly connected to meth, but it is reminding me of a presentation I was at just a couple of weeks ago. I think the other thing that's really mixing in here, right, is what scares me is the fake pills, right? When people are using things that are not prescribed to them because they think they're very similar, the chances of getting something mixed with fentanyl or with another substance that's really dangerous is pretty high. Mm-hmm. Nephew who just has gone through rehab for meth, he was sitting at our uncle's house. The sad thing is our uncle passed away in 2020 due to COVID. Esther, thank you for sharing that. And you know, that's part of what I think is so important about collecting this qualitative data is that every single one of those numbers in Nicole's slides is a human being, right? And we sometimes can forget that, or, you know, we all are in this work because we care about the human beings behind it. But when we're just looking at numbers all the time, we sometimes forget the stories that are attached that are so powerful. Oh, I'm getting a little teary. That caught me off guard. Thank you for sharing, Esther. Okay. So I want to keep us thinking through some of these pieces. And I want to think about, for you all in your work, what does this mean for you? How can this be a tool for you to do your prevention work, right? Qualitative data collection really gives us a lot of information about context, but because of that, the context really, really matters. So what's true in Kentucky might not translate directly to what's true in New Mexico or in Ohio. What's the sort of reasons behind what we're seeing for polysubstance users might be slightly different for those people who are just trying to one-to-one trade out Adderall for meth, right? And so really thinking about how might you want to collect data that really speaks to the groups and communities that you're working with and that you want to understand more information about. So when I'm thinking about this, and I see there's more happening in the chat I can't keep up with, but I promise to catch up in a minute. When we're thinking about this, I think the core question is going back to that quantitative data, seeing what those trends are. What do you specifically want to know more about? What is the quote unquote research question that you want to understand? And I put that in quotations because I think we hear the term research question and it feels like, well, that's something I would do if I were a researcher who was going to do this multi-year study with a representative sample of XYZ LMNOP, right? But really the research question is that overarching, what do I want to understand? And it might be slightly different from the questions I actually ask people I'm talking to. So what do I want to know? And then who's going to have that answer for me? Because if I'm trying to understand what teens who are out of their ADHD meds are turning to meth for, that is going to be a different group of people and different questions than the people who lost their job in the coal mines that I'm trying to understand why their meth use rates are so high, right? So really trying to think through, who do you want to get that information from? And then that can lead into, how can we best gather that info? And with that, you're thinking about, what resources do I have? What do I really need to know here? Who's going to be the best person to talk to? And I did kind of run through these earlier, but I just want to take a second and talk about the different options for data collection. And this is not an exhaustive list, but I think these are some of the most common ones, especially that community workers are able to engage in. So first is we might look at interviews. Interviews can give insight into the experiences and choices of individuals who use meth to help us understand why and how they do, so that we can work to prevent those circumstances. However, accessing those impacted individuals can be difficult. It can be hard to gain trust. It can be hard to gain access. It really depends on your community and who you have connections with. There's also times when we might be able to get that same information without actually requiring people who are using to participate. So I always, when I'm talking about data collection, want to challenge us to think about, are there any scenarios where we could actually be unintentionally exploiting individuals with that lived experience if we could get the data from someone else without requiring them to be part of it, right? Just a thought to stew over. So another method would be focus groups or listening sessions. And those are two slightly different things, but they're both surround sort of getting information from groups at once. This can be less time intensive. It can be a good way to engage individuals who are impacted sometimes. So that could be people who are using meth, or it might be family members. It might be a selected or indicated population who's at risk of using. There's different ways to think about it. Again, you want to think about what you really want to know to decide who would be the right group. In focus groups, you're not only getting input from a whole group of people in a short time, so that helps with the efficiency, but you also get to really hear them react and interact with one another, which can be what I think is part of the magic of focus groups. It can be less intimidating to someone who wants to participate rather than like a one-on-one interview, because it's not like spotlight just on them. But on the other hand, in an interview, you have a lot of control over what happens with the information they share. You can keep it really anonymous. You get to tell them how their privacy will be protected. In a focus group, because there's a whole group of people there who have their own free will, you can ask folks not to share what they hear in the focus group, but you don't really have any control over that. So that really is something, again, to weigh as you're thinking about how you want to collect information. Additionally, some people may not be comfortable sharing their story, especially if it includes really vulnerable or sensitive information in that more group setting. So those are the kind of things that you want to weigh. Another option is through open-ended survey questions. So that can be a great way to really ensure some more anonymity to folks. And so you can get more sensitive information that way. If you're already running a survey, or if you can partner with a group that can be an easy way to maybe add a question or two to get some really rich qualitative data. You also want to be really thoughtful about how you word your questions so that you get the data that you're looking for, because in a survey, you're not going to be able to ask any follow-up questions the way you would in an interview or a focus group. Just a little plug, this is a really good place to ask for some technical assistance, and the PTTCs are really happy to help you with that kind of work. A sort of downside or challenge to the survey questions is that depending on the number of responses, you might end up with a ton of data that needs to really be read through or maybe coded or otherwise kind of made meaning of. So you want to think about that piece when you're thinking about how big this survey is. You also might get participants who are really happy to answer the closed-ended survey questions, but skip over an open-ended one, which could lead to a lack of data. So again, it's the same thing each time, really thinking about who you're trying to get the data from, what's the context to decide if that's a good fit. And then the last one that I'll talk about, and again, I mentioned this a little bit, but if not interviewing impacted individuals, there are key informant interviews. So those would be conducted with community leaders, on the ground staff, folks who have a lot of knowledge about a topic, but don't necessarily have lived experience or aren't the people who are currently being most impacted. They probably aren't currently using. In this case, that might be interviews with preventionists who are working to address initiation of meth use, or with recovery coaches or therapists who are working with people who use or previously used meth. And the questions you ask these people will likely be a little less sensitive than what you'd ask someone who's currently impacted, but they can be a really great source of data because frequently they've worked with enough individuals that they can sort of identify patterns and trends and give you a lot of information in just one interaction. That was a whole ton of information. Let me pause. I'm going to read the chat and let me know if you have any questions about this. This is a great question about the chemical compounds of meth and Adderall. I don't know, and I don't want to misspeak. If anyone on my team does know and want to chime in the chat, please do. But also, when we send out the notes from this presentation, I can find a couple of resources around that so that everybody can have access to it.
Yeah, I don't know either, and my chemistry was not good, y'all, so I don't want to speak on that. We will find out.
Yeah. Any questions on these data collection methods before I move on? Okay. So we are going to give you a chance to kind of think about this for yourself for a few minutes. So we're going to, in a couple of minutes, open up some breakout rooms and put you all into them. I can see people leaving by the minute as I said breakout rooms. Please stay. You don't all have to talk, I promise. I have a set of Google Slides, which are just dropped it into the chat. On those slides, let me actually see if I can stop sharing and bring those up so that I can show you what it is that we're going to ask you to do. You can see it's not at all scary. Just need to find the right one quickly. Oh no, there we go. So you see, this is the side primary qualitative data collection planning. And each group, your room, it will tell you what room you're in when you go into the breakout room. I'm going to ask you to drop your names in, first names. You can use an alias or a made up name if you want to. That's not the point right here, but just who are you? And then first, I want to ask you each to share a little bit about questions that are coming up for you for your community around meth use and what is it that you'd like to investigate more. And then after you take a couple of minutes to do that, we'll have Richard send a little note into the breakout rooms to let you know to switch gears. And at that point, choose one person's question and work through a little bit. What's the topic? Who would you need to learn from? And then what method would you use? And so that's what we were just talking about, those focus groups, interviews, survey questions. And then if you have enough time, you can start to brainstorm some of the questions you might ask. Put your notes into the slides so that we can all see them. We'll come back together and we'll have a couple of minutes for some folks to share. Any questions before we move into those breakout rooms? Okay. All right. Richard, would you please open the rooms? Thank you. And it looks like there's a couple people. If you're having any trouble getting into your room, let me know. Camilla, did you just get kicked out of a room? All right. So Camilla and Aaron, if you are having trouble getting into a room, let me know. We can certainly help you get there. Great. We'll assume that if you are still here, it's because you had to step away for a second.
I pushed Aaron into room 4, but she still hadn't joined, so.
Okay. And Camille is in a room too, right? Yeah, room 7. Hi, Joanne. If you need help getting into a room, let us know. All right, some folks are working in there already. So, Richard, at the 5-minute mark, if you can just send a note, actually, I can do it, the broadcast.
Okay.
So I'll do it in a minute. Yeah. It always feels a little bit like a miracle when I check the time and we're right on pace.
I bet that's right.
I know that's always a good feeling.
And feels like something I have no control over.
Right.
It just happened.
Yeah. Yeah.
All right, I'm gonna push this out to the rooms in 1 minute. And then, do you already have the time set on them, Richard?
Yes, I do.
Okay, great. How much? I don't know what time they actually went in there. How much time do they have left?
We're coming up on 5 minutes right now.
Okay, perfect. All right, we still have 2 rooms where no one's typing in the slides. I can pop into one. Does someone want to pop into the other one and just make sure they're speaking?
So that'd be
So I think that's 1 and
7.
1 and 7. I'll go to 1.
I can go
Okay.
to 7.
Okay.
We had a good turnout today.
A little bit lower. I thought you were thinking
I
it'd be
know.
around 100, but
I did too.
Yeah.
I thought that we would have more people.
I'll give them a 5-minute warning. We're at 8 right now.
Okay.
So that is kind of true about what she said, but I wasn't going to answer it about the meth.
Yeah.
But that's a big deal. I mean, like an analogy would be like water is H2O, hydrogen peroxide is H2O2, and one you can't drink. I mean,
Right.
but anyway, I don't feel like I should answer it though.
It's you're the chemist in the group.
I am, but not that.
Okay. Not that kind of a chemist.
Mm-mm.
Okay. You would probably know what you're talking about more than most of us. Okay. She'll be able to get them something. I mean, I kind of feel like
Okay, that's 10 minutes. I'll give them that 5-minute warning.
Sounds good. The group I popped into is working. They're just talking through it all, which is great.
oh, good.
Good conversation.
I was telling her, Katie, that that is sort of true about the one like molecule different, but it's a good analogy is water is H2O and hydrogen peroxide is H2O2.
Got it. Okay. So yes, and it's still a big difference.
Yes.
Got it.
I don't know all the pharmaceutical stuff of what that means, but
Right.
the impacts, it is impactful.
Right. Nicole is letting me know that group 7 was filling out group 2.
Oh, okay.
It'll all work out.
Okay.
And I do see there's a couple of people who are back in the main room. We're going to be closing, if you can hear me, we're going to be closing the groups in just a couple of minutes. So feel free to hang tight and we'll bring everyone back together.
Okay, 13 minutes. As we planned for 15.
Yeah, I think we can actually wrap up. Can you give them just like 60 seconds and come back? Because
Okay.
most of them are done. I love a new computer, and I especially love a new cat. Looking in the chat there. Well, and I extra wish that you had a new cat. You're doing great. Don't worry about the camera. Welcome back, everybody, as you're starting to rejoin us. Got too many things on my window because I'm trying to see everybody's faces. There we go.
Yeah, I'm gonna close the rooms.
Great. There's everyone. Glad to see some faces. And thank you all so much for all that you put into the slides. I'd love to hear, is there a group or potentially more than one, but I'll start with one, where someone would like to share with us some of what you talked about. Just walk us through what's on your slide. And I can call on you, but I prefer for you to volunteer. What is it? I can volunteer you who to go, but I'll let you consent your way in. Oh, Norma, thank you for
Okay, I guess I'll. You're talking about group one.
I am now. Yes.
Yeah, we were talking about, different coalitions. We would gather information from, key informants, from the participants themselves, through surveys, or just if, like, I'm a teacher. I teach in the jail and at a rehab center, and I hear a lot of these things from my students. So those with lived experience, people, other agencies and programs that are dealing with the same target population. This would be where who we would learn from.
Yeah, that makes a lot of sense. Did you get to the point of thinking through what kind of data collection you want to do in terms of interviews or focus groups or anything like that?
Well, I think a lot of us were saying, the interviews and just key informant information from other workers in the field, maybe surveys from participants. And I think that's about as far as we got with.
Yeah. Thank you. That's great. Thanks so much. Does anyone, can we get one other group to share what you had discussed? Let's see.
I could share what we were in group 4.
Perfect. Thank you.
Topic meth use in the community. Who do you need to learn from? And we talked about, at least my experience has been, since we provide residential services, to ask questions to those who have agreed for services, who've come in for services. And that the kind of data is like the lived experience data, sometimes asking what was family life like for you? What was school like for you? I usually start with school, and then that usually spreads out to family, community, and so forth.
Mhm.
And I think our last one, what questions might you ask? School life and home life. Well, I've just kind of covered that. It does usually always gives you a lot of information uh,
Mhm.
that sometimes if an individual is connected to the court, we have a mental health court here in Cincinnati, 4 mental health courts. And a lot of times you need that background information to provide to the treatment team at the courthouse because they just don't have that kind of information to understand what is going on for this individuals. What are their struggles?
Mhm.
How is it they, despite having to come and stand before the judge, not turn things around so easily?
Mhm.
Um, those asking those questions about their home life and getting a real understanding of what their struggles are and how long they've been dealing with them really helps
Mhm.
sometimes navigate through the various systems they have to go through.
Yeah. Yeah. And, one of the things I appreciate about those questions is that, the overarching question, the reason you're trying to understand more information, right, is about some of those underlying causes, what's bringing people to use meth in the first place. But you're not going to necessarily ask that directly. You could, but you're going to get different information if you start with, what's your school life like? What's your home life?
Yes.
Like then if you just went in and said, well, why are you using meth? Right. So it gives you, I think it's a really good example of how these interviews can be really effective once we start thinking about what kinds of questions will get the data you're looking for. Yeah. Thank you. There's so much great stuff here on all of these slides. Please feel free to scroll through and look at what some of your colleagues came up with. We won't go through every single one, but I think this is a great way to start thinking through what would it be like to do some of this data collection yourself. I'm going to go back to our slides. That's not the one I want. This is the one I want. All right. Can you see the slide that says breakout rooms? Perfect, or breakout groups. Excellent. All right. So this is sort of the starting point to think about that qualitative data collection plan. And I will say, the third objective of our webinar today was really to develop the qualitative data collection plan to better understand the gaps that you are defining and identifying in the quantitative knowledge regarding meth use for your community. You've already started thinking about some of that big picture stuff, thinking about the research question, the participants, and the methods. And then the next step is really to think through, like, what would that look like? So I talk about the qualitative data collection plan as a way to put everything in writing and have kind of a step-by-step guide to follow. So you, just like a physical scientist might have protocols written out of like, how are they going to do their research, right? When you're trying to collect that data, you want to do it in a systematic way that really ensures that you're thinking about how am I getting consent from people who are participating? How am I making sure that people really understand what I'm asking them to do and they're comfortable sharing with me? What are those really thoughtful questions that I'm going to put together so that I'm getting the data I'm looking for? Am I going to take notes? Am I going to record it? Am I going to have somebody else there who's helping to record those pieces? And then what am I going to do with the data once I have it? How am I going to turn it into making some meaning? This is not like a simple, oh, okay, I'm ready to go, let's do it. But this is another place where you can get some really great technical assistance to help put some shape around a plan like this, if that's what you want to do, to be able to, again, go back to that big picture data that we're looking at and understand, how does this apply in my community? How does this impact the people I'm working with on a day-to-day basis? So we've made it. in about 90 minutes, we were able to really look at some of this data around meth use and mortality. So we started by just reviewing that over the past 25 years, there's been a 50-fold increase in meth mortality rate nationally, and that adult meth use rates in most of Region 6, which is the South Southwest, are higher than that national average. We understand from looking at the qualitative data that meth use is driven by individual, interpersonal, community, and societal factors that can be investigated using that qualitative data. And we really took a look at the qualitative data collection plan, starting with the research question, and then thinking about all the specifics of how you could fill the gap in the data that you identified. As we sort of move into some of our wrap-up pieces, I would love to hear from you all again in the chat. Just one thing that you're taking away today that you think is going to be useful in your own prevention work moving forward. And sort of, what are you getting out of this hour and a half you spent with us? And while you put that in the chat, and I promise to come back around to it before we leave, but Nicole, do you want to talk a little bit about our session 3 that's coming up in September?
Sure, thanks, Katie. So join us for part 3 on September 23rd. And we'll be talking about our Lunch and Learn product release. So we're going to take a lot of the information that's in part 1 and part 2 that you just heard today and put that in a nice brief format for you so you can share with your partners. And so we'll have a little trivia. We'll go over some of the things we've talked about and kind of bring it all together in part 3. So please join us for that.
Thank you.
And then
sorry, go ahead, Nicole. I didn't mean to interrupt you.
That's okay. And then we also have our evaluation for today. So please take a moment to fill that out. And Richard has posted the survey link there for you.
Great. And as some folks are filling that out and we're wrapping up, I'm just going to share some of what I'm seeing in the chat as far as takeaways. So definitely an emphasis on the qualitative data, thinking about describing what's going on in our specific communities, a new way of looking at the socio-ecological model in terms of substance use, the increase in meth mortality over the last 25 years, and the info that meth use can mitigate, or that users feel like it really mitigates that withdrawal symptoms of other substances, resources and example, and gathering information. Surprised that Oklahoma is on the higher end of the percentages. Yeah, Angela, that definitely stands out to me as well. I think getting qualitative information really helped understanding where people are coming from, which will help me meet people where they're at. Thank you, Stephanie. I also didn't know the high prevalence in the Southwest. Qualitative data gives more of the why, not just the what, and helps form more questions to better understand current conditions. Thank you. Well, I will just wrap us up by sharing my contact information. I'm really happy to continue these conversations, particularly if you are in the South Southwest. I would love to talk with you about what's going on in your area and how you could get a little bit more of that qualitative data to understand some of the specifics. If you're not in the South Southwest, we can absolutely connect you to the right person to have those conversations with as well. And then we will be sending out this recording as well as the slides, so you'll have access to all of this within the next week. But some of what's in here is that we do have some resources. So the recording of the first part of this series, or actually that's not what's on here. What we do have is an article here on meth trends in Region 6. We also are linking to a really nice symposium that was done on meth in particular. They have a number of different sessions that were recorded there that you could take a look at. And then the PTTC has put together a review sheet of different primary data collection methods. So if this is something you're interested in, there's a nice overview available there. And then, of course, we have the references for the different qualitative studies that we talked about in this session. I am so happy to hang out. I don't know how we ended 5 minutes early. Again, feels like a miracle when timing goes well. But I'm here, Nicole's here, Sheila is here. If you have any other questions you want to talk through. And I think for anyone who is hanging on a second, I will circle back and say that question about Oregon, I would point you to their PTTC. And if anyone specifically does want a connection to them, I'm happy to send you an email, put you both on an email so that you can have some of those conversations as well. Great. You are free to go and also happy to talk a little bit more.